is about industry contribution to the development of effective global and national pharmacovigilance system. We have two presentations. The first and we have a slight change in our program. First presentation is differences in pharmacovigilance regulatory requirements in Latin American countries, and I will ask the presenters to come to the podium, please. The second presentation will be industry perspective, and I also was kindly asked, and I just could not say no, that we have, after these two presentations, the presentation of abstract, number 46, Initiative to Increase PV Awareness and Support Access to Medication for the Patient. I would like to invite our first presenter to come to the floor, Pisani or Hernandez.
Okay, hi everyone. Thank you for the opportunity to present our abstract as an oral presentation. My name is Karen Pisani. My name is Karen Pisani, and together with Vivian Hernandez, we are representing this group. Okay, I must say that the content of this presentation expresses the group opinion and not necessarily our employers. Okay, so this abstract was written by a group of colleagues. As I said, Vivian and I are representing this group, but we also have some people in the audience and also some other people that were not able to come. In Brazil, we have an association of pharmaceutical industries called Sinduspharma. In Sinduspharma, we have this regional pharmacovigilance group. This group started in 2012 with the aim to contact regulatory agencies to clarify requirements. Also, this group get together to discuss these requirements and also to share experiences. In 2016, for different reasons, this group was reorganized. In 2017, we decided to express our opinions in different forums. In 2018, we presented a poster at the Instituto de Salud Pública Congress in Chile. And in the beginning of this year, we started the preparation of this abstract, and here we are now. Okay, so why have we decided to study this topic? We have observed that regulatory requirements were published between 1969 to 2019. MOH websites for regulatory search and updates were non-friendly at all. Sometimes publications were not issued by regulatory authorities channels, but through non-public domains. And as we all know, the infrastructure and capacity at the health authorities need to continue to evolve. We know we have a long pathway. We have already started to walk in, but there is still a lot to go. Okay, so this is the face of our abstract. The objective of this abstract then is to compare PV legislation requirements of 18 countries in Latin published until May 2019 to evaluate the impact of its divergences of the market for the marketing authorization holder. As material and methods, we have analyzed data for Argentina, Brazil, Bolivia, Chile, Colombia, Costa Rica, Dominican Republic, Ecuador, El Salvador, Guatemala, Jamaica, Mexico, Nicaragua, Panama, Paraguay, Peru, Uruguay, and Venezuela. We have analyzed the requirements for individual case safety reports, aggregate reports, risk management plan, signal detection, case reports published in the scientific literature, internal audit or self-inspection, and the requirement for having a PV responsible person for PV. Let's see. As a result, the results suggested an important variation between timelines, terminologies, and definitions. And what we're going to do now, we're going to talk a little bit about these variations. We can see that, speaking about aggregate reporting format, we can see that 44% of the authorities does not specify the format. 28% requires a PBIR format. 22% requires a PSUR format, and still 6% requiring a local form. I'm happy to see that 26% already started some movements to use the VISFlow. And going to the regulatory reporting timelines for ICSR, we can see that there are, for serious cases, there are countries starting timelines from 24 hours to 15 days. And for non-serious cases, there are countries that require 72 hours to 90 days. So you can see the discrepancy between them. Now my colleague will continue with the discussion of all these topics.
Let's continue talking about the impact of all these differences that we faced into all the evaluation. So the difference just presented before turns the process very fragile, as we need to follow so many rules in each country and also jeopardize the regulators to exchange information with each other properly. Well, saying that, to be compliant with all this regulation, we invest a lot of time understanding and also training all the PV people, from regulatory to public health to industry, so everybody. This creates a lot of distraction, consume a lot of time and resource, impairing the time that we should focus in data analysis. So we need to stop being just reporters and be more analytical data than we're doing now. We still have isolated system between one and other country. In Latin America, we see this evaluation, but we still don't have a regional system. So it's very important that we work on it together. Remember that due to also multiple and consecutive translations, we might have significant loss of consistency of ICSR submission. So this could strongly impair in our data integrity. Another very important point in this difference is the difference between the aggregate reports. So we have different formats, we generate different period of times, and the most important thing is that the drugs is with a personal analysis, not a completely figured. And we will still have individual cases submitting in physical, another format, local format, and different minimum criteria. So we have the impacts, but we also have the benefits when we are talking about harmonization. The harmonization will provide less operational and more analytical process, improve efficiency, enabling risk management planning and risk-benefit evaluation of all the products. We will have smooth exchange data between the regulatory authorities, improve the data evaluation, and joint decision-making between one or more regulatory authority and the regulators. So a region website should put in place as a public and available to HCP and patients too. This will improve the transparency, understanding, and have a comparable data. There is already a movement, as Karen just said, in some countries like Argentina, Brazil, Peru, Ecuador, and Mexico. They accept the XML files in English, and also the implementation of the flow system in some of them. So this will help us a lot to make this comparable data put in place. This demonstrates a progress in the standardization of our information that we might going through, and we should go on that until all Latin countries are in place with all this new system. The implementation of a regional system would help a lot to eliminate communication barriers, such as the language, and also the deadlines, and increase the consistency of our ICSR submissions. And the aggregate report harmonization is the other big milestone when we are talking about harmonization, because it provides systemic review and not more figure stopped on that period of time, and this could help a lot the regulatory authority to have a clear picture of the same drug at the same time, because they could compare both of them. So we will have to improve the risk management plan at the risk evaluation benefit on this, because they will compare both of them together. By working in close cooperation, the countries reduce duplication, sharing work practices, and ensure the regulation is really efficient and effective. So, in conclusion, when we have all the impacts, all the benefits, and we go through all of that, the harmonization brings more effective system that will be able to share safety information between regulatory authorities and eliminate unnecessary complexity. Implement a PV new regional scenario consistent with the international one. When the impact of this divergence is mitigated by the benefits of the harmonization, we will ensure the patient safety. This is the end for us, because patient safety is what we are looking for. Okay, thank you.
I would like to thank our speakers, and in the best interest of time, I would like to invite our two next speakers, who will be presenting industry perspective for two large regions, Latin American and Asian. And Jean-Christophe, I don't think that I need to particularly say a few words about him, because we know that he, in fact, is the ISOP board member, and he put us in a very good financial situation, what we just heard. He is currently employed by Bayer. Our next, second speaker, Gillian, she is actually safety director at Amgen, and as I mentioned, both of them will present industry contribution to the development of effective global national PV system. Thank you.
Thank you very much, but I need to update a little bit. If you look at your app, you will see that there is a discrepancy between what is printed. I'm not going to present anything particularly to Asia, but it's Gillian and myself will make a joint presentation on three strategic objectives of the EFPA. And she will actually be the first speaker, and I will follow up on a presentation. So it's more Latin America and global approach, but not particular to Asia.
Thank you, Jean-Christophe. So thank you to Vivian and Karen, first of all, from Synthes Pharma, for sharing the important work they have conducted to address the challenges with the lack of harmonization in Latin America. I would like to build on this by sharing the work of the FPA International PV Group, which provides technical support and resources to advance PV in all regions around the world. As we have heard throughout this conference, PV requires input from multiple stakeholders, and multinational pharma companies and the trade associations that bring these organizations together are just one stakeholder. However, we all need to work together in the spirit of openness and transparency to meet our goals to protect global patient safety. An industry has a long history of contributing to the development of effective PV systems. Industry was a founding member of ICH, and yesterday we heard from Jose Vega about the Transcelerate initiative that has reviewed and evaluated different sources of data, such as those from market research and PSPs. And through this industry momentum, ICH have opened up the review of ICH E2D to incorporate guidance regarding the use of newer data sources, which will inform worldwide practice regarding handling of this data. In addition, industry routinely contributes to the review of new regulations, and this input supports the successful implementation of new regulations and guidance. And as a global industry, we can bring this experience to individual regulatory authorities, because multinational companies have the benefit of interacting with regulators from around the world and can share these best practices. In addition, industry supports the harmonization goals of WHO and PAHO through supporting projects such as the joint evaluation of PSURs and RMPs. So how can industry support regulatory systems? So we can provide this support through technical knowledge. So in the UK, there was a joint forum called the Innovative Medicines Initiative, and this was a forum between industry, academia and agencies that ultimately led to the development of WebRadar. And WebRadar, as you may well have heard of, has been expanded outside of the EU to strengthen pharmacovigilance in all regions. In addition, we can provide education and awareness through sponsorship or provision of speakers to promote the culture of adverse event reporting. And actually, industry has a long history of supporting academic courses on pharmacovigilance. We can also provide global pharmacovigilance knowledge to support the development of PV systems and best practice sharing. And one such example of this is the Vigilantia example that was rolled out in Latin America with the support from ISOP as well. So I'd like to share 3 initiatives that the FPI IPVG group are working on. So the first is around the LATAM initiative to evaluate the divergence of PV requirements. And I think, as we've already heard, it's a challenging time in Latin America at the moment for pharmacovigilance. And I think it's a really good time for ISOP to be here and bring that PV conversation to the region. The second initiative is simplify and improve global ICSR reporting that John Christophe will update you on, as well as the effective PV system development. So I'm going to focus on the LATAM initiative, and I would like to thank, we have several members of the project team who worked on this specific project in the audience. So I see Santiago Schiaffino here at the front from Boehringer. I don't know if Marco Curie is here. I know he's at the conference there. He is at the back from AbbVie, thank you. As well as our broader LATAM FPA team. So Pedro Lima, who you heard from earlier today from Sanofi, and then also Priscilla Ushida from Takeda is also here today. So I'd like to thank them for their support. So as mentioned, I am an employee of Amgen. So what was it that led us to look at Latin America? So we've already heard from Syndus Pharma today about the divergence in country-specific requirements. And we really wanted to understand the current environment in Latin America and support the WHO global benchmarking tool indicators, as well as the PANDRA initiative around regulatory harmonization. And as WHO have stated, an effective PV system requires regulatory convergence and harmonization. So to better understand the LATAM environment, we conducted a survey in July of this year to understand the impact of the lack of harmonization. And I'm going to share that data with you today. And This is the companies that actually participated in the survey. So I know several of you are here today. I know Gabriel Pardo and Andrea are here from RAFO, and they participated. And in total, we had 84 responses, and these were the countries that we focused on. So when we were looking at this data, it's always hard when you're doing these broad surveys to know where to focus. So we want to quantify the impact of the responses and the efforts towards harmonization. And so we applied a numbering system. So we had positive numbers, so +1 or +2 if there was lack of harmonization, and negative numbers if there was harmonization. And this really gave us a heat map that told us where to focus. And when we saw the results, actually it matched kind of our experience and what we predicted, but it was nice to have the data to back up those results. So we can see from our results that the greatest disharmonization was predominantly in Brazil, Colombia, and Mexico. And obviously they are some of our largest markets and role models for other countries. So it's important to address. In addition, with regards to processes, there were certain aspects within management of ICSRs, within the PBRs, and within our MPs that really came up as red. So now I'll focus more in depth for the countries we want to focus on. So for Brazil, you can see some of the challenges with regards to translation of ICSRs, the birth date and periodicity of PSURs, and lack of alignment with the international birth date, as well as compliance with 2 or more regulatory entities. As you may know, in Brazil, we have Anvisa, but then also for a lot of the companies are based in Sao Paulo and have to report to CVS Sao Paulo as well as challenges with implementation of local risk management plans. And actually, we've heard a lot about risk management plans over the last couple of days. With regards to Colombia, we saw challenges with regards to format of ICSRs and method of transmission, as well as with regards to preparation of the ICSR line listings, those are the bi-monthly line listings, and the expedited review reporting timelines, which is the 72 hours that we heard about earlier, as well, again, creation and implementation of local risk management plans. In Mexico, we heard about the requirement for translation of ICSRs, again, expedited reporting timelines, and the PSUR submission deadlines and translations, and again, the local risk management plans. So what are the recommendations we should consider if we want to move towards harmonization? Well, in terms of systems, we should recognize the use of XML and the E2B standards that have been developed by ICH, and particularly rely on the local field that allows capture of the local language narrative. We should adopt globally accepted timelines and also bring consistency to the type of cases that need to be reported. In terms of PSURs, we should align the format to the ICH standard and international birth date. And this will allow alignment with production of country-specific local benefit risk assessments where they are needed. And with the aim of bringing harmonization, this doesn't only just reduce the administrative burden, but it also facilitates a true global benefit risk assessment. And we should also apply reasonable judgment with the need for translations of large documents, such as PSURs. For risk management plans, we should utilize the robust framework developed in the EU and support country-specific annexes as needed, and also take a science-based approach regarding the need for risk management plans, particularly for older products where the benefit risk is very well established. And this harmonization will bring benefits to patients, to regulators, as well as to industry. And by reducing the risk through a stepwise introduction of a pharmacovigilance system, this allows for resources to be targeted to areas of greatest risk. And also, by reviewing summarized outputs, this ensures the reviewer does not miss significant safety information. It will also allow us to gain efficiencies by focusing on collection and assessment of local cases, recognizing that major regulators are already conducting global signal detection activities. And it will also allow us to focus our resources on more high-value, impactful activities. And it will help us achieve our goals of adopting ICH standards, allowing for well-thought-out PV systems and definitions to be implemented, and I think ultimately avoiding any gaps in reporting rules. And it will also allow us to share globally accepted documents and ultimately ensure patient safety is protected. So in conclusion, we've seen that the regulatory environment continues to evolve. Even since we did our survey, we've seen significant changes in the PSUR requirements in Mexico that I'm sure many of you are very familiar with. We've seen, on the positive side, we've seen some steps towards harmonization. Brazil are fully implementing the ICH guidelines. Mexico are utilizing VigiFlow. But we really still need to continue to work together to support the PANDRA initiative for regulatory convergence and ultimately meet the WHO goal for harmonization, which will enable a more effective regulatory system and support international collaboration. Thank you. I'll pass over to Jean-Christophe.
Thank you very much, Gillian. So
Gracias, Gillian.
Right, so we continue with two more EFPA initiatives, both of which are actually global strategic initiatives. So this one is called SIGIR or SIGIR, and it actually means, so I should have presented the disclaimer first, that I'm just expressing my own views and not those of my employer Bayer or EFPA or ISO. What does SIGIR mean? So it stands for Simplify and Improve Global ICSR Reporting. It's a strategic initiatives of the EFPA International PV Group. You may know that in EFPA there is a PV group called PVEG, which is basically a group of QPPV, and about 2.5 years ago there was a decision to create another EFPA PV group, but more looking at the rest of the world, not EU, not US and Japan. So we are part of this group, which has defined the strategic initiative, which Gillian mentioned at the beginning. So SIGIR, what's our role? It's to first monitor the global ICSR submission environment. We monitor it closely. And the idea is that, because in this position, having experience of submitting ICSR to all countries in the world, asking for it, we have accumulating a treasure of experience which we believe is valuable for health authorities, and in particular to health authorities who are interested moving to E2P. Yeah? So the idea is that we take advantage from this experience accumulated by EFPA member companies in submitting ICSR to national regulatory authorities all over the world. So we are keen to advise and collaborate with national regulatory authorities. We are wanting to move to E2B or improve their ICSR submission system. So who are we in this CIGER group? So we are a sub-team of IPVG, IPVG, yes, International PV. But as we are usually not PVIT specialists, we also have a circle of PVIT experts from our companies, our respective companies. And we also have a network of ad hoc members, maybe from PV software suppliers, which may contact on an ad hoc basis. Our operating model is not to interact directly with health authorities, although in some circumstances we may, but our standard working model is to work through country pharma associations. So basically, whenever in the country the health authority is interested moving to E2B, then we basically provide knowledge to the local pharma association for providing knowledge to the health authority to propose to collaborate, and we support them. And occasionally we may actually interact with health authorities. So what are these valuable experiences which we are keen to share? Well, there are, for example, the pros and cons of the different solutions for moving to E2B, or the challenges faced by countries who decided to set up an E2B system with the local companies and who actually happened to struggle, and a number of them failed. So having experience, having discussed with those health authorities about their challenges, then we are in a position to advise other health authorities to avoid embarking into an avenue which would be not so likely to be successful. We can advise also on avoiding customizing E2B core elements, because these customizations practically leads to delaying the implementation of the system, because it's a source of back. And there's a number of countries who had a lot of problems with that, which we try to help, however. We can also advise on how to configure E2B for submitting contents in native languages, because there is a change between E2BR2 and E2BR3, and E2BR3 is much better designed for hosting local languages, but there are different ways to do it, to use that, but there is one way which is the most optimal, so we can advise on that. We can also advise on how to use MIDRA and how to overcome that. The MIDRA dictionary may not be available in certain languages, and also anticipate the future of drug dictionaries, because there is a new standard which is coming, which is ISO compliant, and it's important to be in the perspective of this upcoming change. We can also advise on the pros and cons of the different e-submission methods, uploading tools or gateways, and we are keen to provide files to connect among the EFPA member company to provide XML files for testing the system that the authority would have put in place. And we are also keen to advise on how to use an E2B system in which we avoid duplicating work and avoid resource. And I want to pass the message that a suboptimal setting, which results in consuming a lot of resource from the license holder side, usually also creates a substantial consumption of resource on the health authority side. So it's really our interest to work together, to discuss together, in order to make an optimal use of the E2B standard. So again, in synergy with the Country Pharma Association, we are keen to advise the health authorities on selecting an E2B system which would meet their needs, and also in consideration of their available resources. For example, an health authority would have very little resource available. Creating a PV system which they would have to maintain would be too resource consuming for their capability. So in such a case, a solution like VGFlow would would appear much more appropriate. So it's very much resource dependent. So we can advise on that. We are keen to advise authorities how to maximize the advantage of having a VG-flow license. We had example of countries who are using VG-flow, able to receive excellent files, but we are still asking ICSR on PDFs, and they would have to re-enter it. So it's very surprising that how non-optimal use of VG-flow can still be done in some countries. We are keen, of course, to advise on how to configure it to the systems in case, let's say, how to guide an implementation guide in case the country really needs to customize the E2B system. So what do we advocate for as a rule? And we are very transparent with that. We advocate for harmonization for the reason that were already explained in the two previous presentations, because lack of harmonization practically results in wasting resources on both license holder and health authority side. So we advocate for aligning ICSR submission requirements with internationally agreed standards. We advocate for acquiring an E2B system from an experienced vendor rather than asking for a local company who has no experience. We advocate for avoiding to deviate from the E2B core elements because that's a sort of bug. We advocate for accepting ICSR according to the international submission format, or in case local language would be needed, to use it using the so-called H5R field, which has been designed especially in E2B-R3 to host contents in local languages. We advocate for a submission via gateways. Unfortunately, there is no gateway for VG-flow now, but we have some hopes that this can change in the future. And we also advocate for the use of VGLIs to get cases to get international cases. Because, a search in VGLIs is more powerful, knowing that VGLIs is a tool to search into VGBase, 20 million cases. A search in VGBase is always more powerful than a search into a collection of foreign cases that any country may have collected. But in Latin America, there is, I am not aware of health authorities requesting foreign cases, so that's a good point for Latin America. What about VG-flow? So yes, we advocate for VG-flow, but we are not at all in a situation of conflict of interest with the UNC. It's not, and it's not because they are nice people, but it's just that they provide the tool which we believe are the most suitable for most countries. And these solutions are most affordable compared to systems which may have to be maintained locally, or which would be far more expensive. So why do we practically advocate for VG-flow whenever possible? Is that this system is ready, it's an E2B-R3 system which is readily available, which can support national database. So don't confuse VGBase and VG-flow. VGBase is the name of the WHO database that the UMC is appointed to maintain, and VG-flow is a system to support national PV databases, and it's structured in a way that the data are in a country-specific container owned by the country. The country has full control of the container, but the system is a clouded system, and each individual country doesn't have to maintain the system from a physical and IT point of view. Just internet connection and a laptop would be sufficient. So we advocate for the optimizing for multiple languages with the system, because it's optimized for multiple languages, and also it's the advantage is that everything can be submitted in one single XML file compared to submission, complex submission as we have in some Latin American countries, where we have to submit through a local system, which is non-E2B plus submit ICSR. So it's an all-in-one ICSR submission system, and with such a system, there is no need for having any other system, basically. So, however, and that's an important point. Even if there is a country as an E2B R3 system operating, such as VGFlow, ICSR reporting requirement may need to be reconsidered in order to optimize the effectiveness of the case management workflow. And I will explain what I mean. I'll show you 3 examples of countries. I'm not going to name what country I'm referring to, but let's case number 1. We have a country which has a non-E2B system, but a web tool, and license holder need to enter the case into this web tool. The content is to be in Spanish, and the submission will be according to ICH timeline, which is good. So in such a case, there is no duplication of work, except that multinational company would also have to enter this case into an E2B system, but the transmission would be according to the all-INTIS system. So it's there is not as many data transferred to the UMC, to the VG base, as if it would be an E2B system. So this is suboptimal. So moving to an E2B R3 system, such as VGFlow, would allow, with the same system, to provide narratives into native language using either the so-called H5 or H1 field, depending if it's a local company or a multinational company, very flexible. Submission within ICH timelines, which would be unchanged, no duplicated submission, and the UMC VG base would receive the case in the optimal E2B R3 format. Now, if we take this other example, so we have countries where non-E2B cases are entered through a web tool, contents should be in Spanish, but the timelines are shorter than the ICH timeline. So this practically results, and there is also a duplicated submission of an XML file in E2B, so the health authority can forward the file to VG base. So then the move would be again to move to an E2B R3 system with the Spanish narrative into the special field. But what's important is that the regulation should be changed to adopt the ICH E2D timeline, and I will explain why later. In this example as well, there is a country where the serious cases are entered within a very short timeline into a into the system provided by the UNC, but which is in principle not intended for cases from license holders, whereas the non-serious case would be sent through XML file. So here we can have an all-in-one system, but again, the timeline should be switched to the international timeline. And the reason is that the ICH countries, which actually produce the largest number of cases, basically set the standard. And the license holder have designed their workflow in a way to fit with the ICH timeline. So if a specific health authority requests to receive cases in a shorter timeline, 24 hours, 48, 75, then they can only receive a case which is not fully evaluated, and then receive the fully evaluated case. So this is a duplication of work for the license holder, of course, but this is also a duplication of work for the health authority, because they will spend time and resources looking at a case which is not complete, whether by just waiting for the ICH timeline, then they would get the complete cases. So even if technically
technically, the technical setting is ICH E2BR3, then if the regulation is still not harmonized, then we still have an issue. And then it's not a technical issue, it's a regulatory issue. Sorry. Yeah. So I will be brief for the last topic, which is PV, the effective PV system development initiatives, which is in behalf of one of my colleagues from Boehringer Ingelheim. So Boehringer and some other companies as well have a kind of global survey to make visual what's the situation of harmonization or disharmonization maybe. So I will move fast. So you see that for PSUR, for example, some countries request the standard international PSUR, some request a local document in addition, some do not request, and some request some country-specific documents. So that's the picture for PSUR, that's the picture for RMP, that's the picture for PV system description requirements, and for the request to have a QPPV of a local responsible person. So the industry is dealing with a pretty disharmonized picture. You've seen that for Latin America. This is true globally. This is a major issue, and this is a major consumption of resource on things where resources may be better used in different areas. So the EFPA, considering the experience we have in dealing with all countries of the world, basically, aware that a number of countries are looking for improving their PV guidance. We have gathered all this experience and worked together on a position paper which is named Effective PV System Development, which is being finalized. I'm not going to describe it to you in details because it's not formally published, but it's pretty well advanced. So we start to contact publishing companies for this paper, and I will just mention the items which are addressed, which is pretty comprehensive. ICSR management, periodic safety update report, risk management planning, PV system description, QPPV local safety responsible person, signal management, signal reporting, safety communication, PV inspection. So all these covered by this document, and we believe that this can be useful to those health authorities looking for upgrading their PV system in the perspective of getting a higher grading in the WHO benchmark tool. We notice that there is a trend toward harmonization, but we also notice that not only the ICH guidelines, but also the EU GVP are used as reference, but the EU GVP reference is so big, 143 pages just for ICSR reporting, that it's not a friendly document to serve as basis for an health authority with limited resources to create an upgraded PV legislation. So we hope that this position paper which is again looking for advocating for harmonization, can be used as basis for setting up PV legislations in countries who are looking for a higher ranking in the WHO benchmark tool. It's a paper which has been having the WHO benchmark tool in mind. So that's all I will say for this initiative. So it's coming soon. You will hear about it published within 2020. Thank you very much.
Thank you very much, Gillian and Jean-Christophe. I know it has been a long day for all of you, and I appreciate staying. Let's give a chance to the authors of the abstract initiative to increase PV awareness and support access to medication for the patient to present their work. Meanwhile, until the presenter comes to the podium, I have a little suggestion to you to stretch yourself, just like do a little bit around your head, so you will feel better. write down the questions. We will try to take a few questions at the end of the session in the best interest of time. Thank you. And I would like to ask our presenter to come to the floor.
Que suban al estrado, por favor.
Hi, hello, good afternoon.
Hola,
my name is Priscilla, and I'm PD coordinator at Beringerheim in Brazil. Today I'm here to present to you an initiative to increase PV awareness and support the medication for the patients. Over the past few years, raising awareness and put pharmacovigilance in the spotlight as an essential area for the patient centricity has been a focus for PV team. No, I want to pass the... Oh, okay, thank you. But just a background, Boehringer wants one of the new oral anticoagulation therapy, the drugs, the NOACs. In the late 2017, BI launched the reversal therapy for the NOAC. The reversal therapy is used when the patient is in use of the BI NOAC consistently and needs the blood coagulation to return the normal level as quickly as possible. In case of emergency, involving excessive bleeding and also emergent surgery. So, the reversal therapy is always an adverse event for the NOAC. This is the principle for the patient safety. So, after the launch of this reversal therapy, pharmacovigilance saw the opportunity to work together with other departments to implement activities to enhance the proper use of the medication, to provide access to the medication, because the reversal therapy is a drug used in the hospital in under special situations. So sometimes the hospital does not have the medication, and in the hospital who has the medication, the stock is minimal. So it's essential to guarantee the quickly support to the patient. And with these actions, we strengthen PV as a strategic area within the company. So everything started with the PV awareness plan, which targets sales representative marketing in medical affairs, responsible for the NOAC and the reversal therapy. The actions were to strongly involve them in case of report situation, such as participation in periodic sales rep web meetings. Pharmacovigilance was rarely involved in this meeting, so we went there with a specific example of reporting situation. Also, presentation in this meeting, pharmacovigilance was also never there, but we were there to deliver PV important messages and also reminded them that reversal therapy use should be always informed to PV. And in this meeting, we started to share with them the local cases that pharmacovigilance received. In this, when we shared this information with them, they got very engaged. And the feedback was very positive, because other areas started to invite us for the meetings with them to share the local case received by local PV. And also, we did periodic meetings with medical affairs to provide, at this time, detailed information of the local adverse case received, to engage MSLs and medical manager to obtain complete information as possible about our cases. So this PV awareness activity was successful once we increased more than 200% the average of the IA reporting in the following months after the implementation of these activities.
de las actividades de reporte sobre este medicamento.
In parallel, we developed a spreadsheet which PV listed all anticoagulation reversal therapy used in Brazil and shared it with marketing and medical colleagues. The information provided has been used by marketing colleagues to update a tool, which consists a local web page where healthcare professionals can search institution where the reversal therapy drug is available using the zip code tool. So the healthcare professional can know where the reversal therapy is available near to them. The market colleague updated the web page using, on one hand, the information provided from the sales information from the wholesalers to add one product in the web page, and also the information provided by pharmacovigilance to reduce the drug in the web page. With this, marketing colleagues could identify any gap in their wholesale information, which allows them to be more assertive when updating the findings. The maintenance of this tool updated is very important for the physician when they are facing emergency situations. These emergencies are unpredictable, and knowing quickly where to send the patient is very important to have adequate treatment, and this increases the chances of full recovery.
Aumentar las posibilidades de recuperación del paciente.
In addition to that, medical affairs colleagues use the spreadsheet that we send to them as a source for several continuous medical educations, such as expert meetings and advisory boards. A consistent information of the local use made it possible for the physicians to understand the local behavior of anticoagulated patients, that it was different from the clinical trial. Since the local use of the reversal therapy was most in the surgeries instead of the bleeding, as shown in the clinical trial. These continuous medical activities with a real local example allow the physicians to discuss deeply and to deal better with the eventual emergency affecting the patients. Also, the information provided by the pharmacovigilance supported some medical publications regarding the experience of the local reversal therapy use. These publications has been presented in Cardiovascular Congress. And the last one, it was here in Colombia last week. So, with the physicians and medical affairs engaged in these publications, PV started to receive a quality and complete safety data for the NOAC and the reversal therapy. Sometimes it's better information than the SAE from the clinical trial. It's very complete and with high quality. So my conclusion here for this initiative is that this initiative ensured mutual benefits for PV, greater awareness and engagement with another department, and, as I said before, quality adverse event data. For the physician, the confidence to know where to send the patients in the support in the emergency situations. So we granted they gave the support for the access, and also the opportunity to discuss the adequate use of the anti-reversal therapy, allowing better care of the patients. So, with more activities like this, does not need to be an elaborate plan, could be simple. We can foster a more compliant culture, which is crucial for the patient's safety and pharma interest. So, thank you.
I would like to thank our speakers. So we heard actually that there is a difference in PV requirements in Latin American countries and the need for harmonization. At the same time, we heard that the industry can help with the harmonization, and we heard some great suggestions for harmonization across the globe. I would like to ask the audience for a couple of questions. Our speakers are still here, so please stand up and ask the questions for ask our presenters the questions. Thank you.
As I mentioned yesterday, the particular initiative that I led around safety issue communication is available publicly, the webinars are available, and we've also, because that project impacted a number of specific countries, we've sought to engage through the local trade associations with those on those initiatives as well. And I think, what I will say is, obviously, I'm speaking on behalf of FPR today, Transaccelerate yesterday, and I'm also an ISOP member, and I think many people are in that position, that they're members of the local trade associations, of ISOP, of other organizations, and so I think we just need to make sure that we are kind of coordinating those items together, and I know Brian mentioned that yesterday, and Jose is going to take that back.
Thank you. Any other question for our speakers?
So are you already engaging
ustedes
with
ya se están involucrando con las autoridades locales para poder implementar Archery. Entonces, ¿cómo planean escuchar a las autoridades locales para poder influenciarlas para así implementar
Just another question.
Bueno, esta es
I
otra
know that there
pregunta.
is
Yo
some
sé
regionalisms
de que hay ciertos
also in
regionalismos
Japan and Korea and
y en
FDA.
Corea.
So are you planning also
Por
to
tanto, estamos
engage with
planeando
this,
también
other
vincularnos
countries
con
to make a
con
global
estos otros países
It's
para hacer un
a
proceso
vast
global.
question.
Sí, que es una
So
pregunta
actually
muy
there are
amplia.
two aspects. One
Yo creo
is
que tenemos
that
dos
we are aware
aspectos.
of
Nosotros
health
estamos
authorities
conscientes de las
who have
autoridades
expressed their
de la
interest
salud.
for moving
Hemos
to E2B.
experimentado
So that's
su
then a
expresión de
relatively
mover
proactive
E2B,
approach.
por tanto es un abordaje
There are
proactivo.
countries where we have regular
Los otros países
discussion on
donde
an
hemos
annual
tenido
basis to
discusiones
make a point
anuales
on
para
what would be
poder
their
apuntar
needs and
cuál
how the
podría ser
landscape is
sus
evolving and
necesidades
what
y
the
cómo el panorama
solutions
está
are.
evolucionando y cuáles son las soluciones.
That's one thing.
Eso es una
And
cosa.
most
Y
of those
bueno, la
countries
mayoría de
turn
esos
to VG4,
países serían a
and
VG4.
there are countries
Y
with
los
larger health
países que
authorities
tienen mayores, unas
who
autoridades
make
de
a
la sanitaria más
decision
grandes, las
to
cuales toman las
move to an E2B system,
decisiones de irse a un sistema
and then we
A2B,
manage
y después
to
logramos
through the local pharma
a
association
través de las
to
asociaciones
get
locales
into the loop,
el
to
poder
be in a position
meter
to
y ser
advise,
parte en una posición,
and to
estar
be
en
in
la
a position
posición de
to
asesorar
support.
y también brindar
So if you
apoyo.
want to get
Si usted
a
quiere
global picture,
tener una imagen global,
Japan is a
por
very
ejemplo,
particular
Japón
case
es un
because they
caso muy
were founding
particular
member of
porque eran
ICH,
miembros
and they had the
fundadores de
Japan-specific
ICH y tenían
version
la
of
versión
E2B
específica de
before
Japón
E2B
de
was
E2B
designed
antes de
to
que E2B
host
fuera
different
diseñada para
languages.
poder
So
acoger
the way
diferentes idiomas.
Japanese is
La manera en
handled
que los
by the E2B
japoneses
Japan is
han
very
sido manejados
specific
por E2B.
and is not
Japón
a
es muy
model
específico
for
y no
other
es un
countries.
modelo para otros países.
Now we have
Ahora
China wanted
tenemos
to move
China,
very
la cual quería
fast
moverse rápidamente
in adopting
en
E2B
poder adoptar
R3
E2B
because they wanted to
R3 porque
become
ellos querían convertirse
management committee member of ICH in
miembros
addition to being just
de
member.
ICH, además de ser solamente
They
miembros.
set up
Ellos
very
pudieron
tough timelines
establecer
which were
unas
actually
líneas de tiempo
unfeasible.
muy
So we were in a position
rígidas,
to have to
así que en este
negotiate
momento
kind of
pudimos
retrospectively
negociar de manera
expectations
retrospectiva
which
las
were not
expectativas
feasible,
que no eran
and they have finally
y
realized
finalmente nos hemos dado cuenta
things we need
que
a transition period, etc.
necesitamos un
So
periodo de transición,
there is
etcétera.
now, I would
En
say,
este momento
excellent
yo diría
collaboration
que hay
through our
una
DPAC in
colaboración
China
acerca de nuestro
to
DPAC
collaborate
para
with Chinese
poder
authority
colaborar con las
to meet their
autoridades para
objective to
poder
have
un
their
objeto
final
que nos
system
permita tener un
rolled
sistema
out
final
by July
que
2020.
se
So
maneje
strong
para
collaboration.
julio
There are
2020. Es una
some
colaboración muy
customization
fuerte,
of the
sí tenemos
E2B core
cierta
elements for China, but
personalización de los elementos para
those
China,
customization have
pero
been
esta
reduced
customización ha
compared to
sido
what's their
reducida comparado
initial
con lo que fue
intention.
su intención inicial.
And the
Y
Chinese will be
los
handled in an
chinos
optimal
van a
way.
ser
The
manejados
contents
de
in
una
Chinese
manera
will be handled in a
óptima,
way
todo va a
which
ser
is
manejado en una
according to
manera
the
que
optimal use of
de
E2B
acuerdo
R3. So close collaboration
R3
with
una colaboración
now with
cercana
the CDR in China.
con el
Now
CBR
in
en China.
Korea,
Ahora en
Korea decided to create their own to be our three system with a local
con las
company.
compañías locales.
We are on board, the local Pharma Association
estamos ahora
and
en la
EFPA supporting
asociación
are
y
on
estamos
board. They have
apoyando
released a customized
en
version
este
of
momento
E2B for
tiene una
Korea.
versión
They have not
para
so much
Corea,
moved from what they
no se ha
had
movido
requested
mucho de lo
originally.
que se solicitó
It's manageable in
originalmente,
terms
es
of
manejable
customization
en
of systems
términos de
on
los
the
sistemas
license holder side,
por el lado
but
de
some
los
customization would be
dueños de la
necessary.
licencia, pero se
The
necesitaría
main
cierta
issue
personalización.
is
El tema
dictionary, is a drug dictionary.
es un diccionario de fármacos, es el tema principal.
There are some
Y hay
issues which are the issue is not tackled at the moment.
no se manejan actualmente,
actually, we have
que de
approached
hecho
the UNC for helping. And in principle, the new system will become mandatory by January 2021.
Por enero 2021.
That's still an issue.
Y eso sigue siendo un tema. En Rusia
decided to create their own system. They appointed a local company. There were some bugs
pudimos ver
which we worked together with them to fix.
Nosotros habíamos que arreglar con ellos.
Sorry, their system is
El
working.
sistema está
There is also
funcionando.
a kind of drug
También
dictionary
tenemos un
issue
tipo
because the
de
drug dictionary
tema con el
is owned by the
diccionario,
ministry
porque esto
level,
se hace a
but
nivel
it's
ministerial,
something on which
pero
we're
es
working
algo en
together
el cual
with the
estamos
Russian
trabajando
authority
con las
to
autoridades
fix this
para
problem.
poder arreglar este
What other
problema.
country could
Otro
I
país
mention? So this
podría
has
yo
been
mencionar.
quite,
Bueno, esto es
this kept us
algo
busy
que
for
nos
a
ha
while.
mantenido ocupados
We
bastante
have
tiempo.
countries like
Tenemos
Mexico
países
and
como
Brazil
México y como
who have
Brasil,
adopted
los
VG Flow.
cuales han adoptado
So then
VG4.
the case can be
Y
submitted, so the
caso
problem
puede
is not
ser enviado, pero el
technical,
problema no es
it's more a
técnico,
regulatory
es más que
problem,
todo un problema regulatorio.
because Mexico, for
Porque
example,
México,
requesting
por
to have
ejemplo,
narratives
solicita tener
in
narrativas
Spanish,
en español.
even if we don't need to
Incluso si no
reconfigure the
necesitamos
system on
reconfigurar
the
el sistema
company side,
por el
this
lado
has an
de la
impact on the case
compañía, tiene
management
un impacto
workflow
en
in order to be
flujo
able
de
to
trabajo
inject
de la
a
gestión de caso
narrative
para
into
poder inyectar
Spanish.
el narrativo en
So the
español.
issue would rather
Así
be
que el
there.
tema estaría ahí.
And in Brazil,
Y en Brasil,
so Brazil in principle
por tanto,
accept the case
Brasil
to
en
be
principio
submitted
aceptó que el
all
caso
in
fuera
English
enviado en inglés.
for international companies.
Para las
The
compañías
problem is
internacionales, el
regulatory is not
problema es
technical.
que es regulatorio no técnico.
Is that the law is not formally enacted.
Por tanto,
So,
la ley no está implementada.
the medical institution enter cases into a web application which gets to their
web.
VG Flow database, which they name
Aquí vemos que, por ejemplo,
it's actually it's a VG Flow system.
Este sistema de VG
But the industry is not
pero la
yet
industria
invited
todavía
to
no está
submit
invitada a
through
poder
XML
enviar a
files. So
través
we
de un
are
archivo
waiting for the law to be
XML.
formally
Por tanto,
endorsed. What other country could I mention? So we heard that Taiwan is moving to as a pointer company to set up an E2BR3 system, and at the last news I had, there should not be much customization necessary. So that's, is there any other country you would like to hear about?
¿Hay otro país del que
I
quieran
think we need to
saber?
leave that for the next time.
Bueno, eso
So
lo dejamos para la próxima.
thank you so much for our
Muchas
speakers, and I would like to ask you
gracias,
for
y
the
nos
big
gustaría un
applause.
aplauso.